Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 23-year-old female who was brought to our ER with complaints of fever, joint pain and swelling of palms and sole for the past 5 days. So, sir, on initial assessment, the patient was conscious and oriented and was obeying commands. Coming to the primary survey, the airway was patent and there was no pooling of secretions. In the breathing, air entry was bilaterally equal, normal vesicular breath sounds heard, saturation of 100% maintained in room air with respiratory rate of 20 per minute. In the circulation, her BP was 110/60 mmHg with pulse rate of 124 per minute and all peripheral pulses were palpable. Coming to the disability, GCS wise, she was having a full score with pupil bilaterally equally reacting and the temperature was afebrile. And we continue with the secondary survey, sir. So secondary survey, she was a 23-year-old female with no known comorbidities and she was complaining of low-grade intermittent fever since the past 6 months. And she also was complaining of joint pain, small joint pain and swelling of the palms and sole. And she was also having skin lesions in the upper limb and on the face. And for the last 6 days, she was also complaining of facial puffiness. And she had history of chest pain and breathing difficulty also. And she was taken to a nearby local hospital where she was initially admitted and she was having elevated CRP with elevated total counts and she was started on antibiotics and blood culture was showing gram-negative bacilli. And they did an echo and echo was showing a vegetation of size 2 into 1 centimeter on the atrial surface of mitral valve with a severe MR. And she was started there with ceftriaxone and vancomycin and she during the hospital stay she was having decreased vision in the left eye and she also developed mucosal bleed with thrombocytopenia and she was transfused with platelets, 4 prime platelets there and she was referred to a hospital for further management. And coming to the other history, there was no allergic history, no significant family history and she was I'm asking, there was no history of any IV drug abuse or there was no history of any recent surgical procedure or dental procedures. And further, we did an ECG. ECG was showing a sinus tachycardia with pulse rate of heart rate of 120 per minute with PR of 114 and there was no STT changes. In the VBG was showing a no acid-base derangement, 7.4 pH with PCO2 of 35 and bicarbonate of 23. A mild hypokalemia was seen in the VBG 3.3 and HV was on the lower side in the VBG 6.7. Echo was done from ER itself which was showing tachycardia was present during the study with good LV and vegetation was seen in the mitral valve, mild MR. And further we send all the routine lab investigations, sir. And lab investigation was showing a total count of 35,000 with a platelet of 6,000 and differential count was showing neutrophil of 89% and lymphocyte of 2. INR was 1.3 and other than that CRP she was having 200 with procal of 5. And she was also having a proBNP of 17,000 and that was all of the initial lab investigation.
His patient is sick?
She was conscious oriented but also she was bedridden.
Okay. So what do you do now in emergency room?
At the present she was maintaining a normal BP with sinus tachycardia. Other than that she was conscious oriented. So our further initial management will be as the patient was been diagnosed with infective endocarditis. So we can start the patient on an IV antibiotics and we had to get 3
How do you diagnose infective endocarditis? Only one sample was taken.
3 samples, sir. 3 samples.
Outside? All 3 samples taken? Okay.
And echo was showing the vegetation. So the diagnosis of infective endocarditis is based on Duke's criteria. So Duke's criteria we can have histopathology and biochemistry, microbiology histopathology criteria and also based on clinical findings. In the clinical findings, we can have like major criteria and minor criteria. If the patient is having 2 major criteria positive, or 1 major criteria with 3 minor criteria, or 5 minor criteria positive, we can say that the patient is having infective endocarditis.
What are the major criteria?
Major criteria include echo imaging showing vegetation. The imaging includes echo 2D transthoracic echo or transesophageal echo.
Okay.
Or right now we have new addition including CT cardiac CT, and also PET scan also.
Okay.
And other than that, we can have blood culture which is showing positive positive organism.
Okay.
And also patient having laboratory investigations suggestive of the same, like HASAC group or IgG IgM positive.
Okay.
Also can be part of the same.
Okay.
And in the minor criteria, a patient having predisposed condition like IV drug abuser, or history of structural heart valve abnormality, congenital abnormality, or prosthetic heart valves, previous endocarditis, these are predisposed to gain the chance of infective endocarditis. And patient is having a fever greater than 100 degree, or if the patient is having immunologic or vascular phenomenon. Here the immunologic phenomena include Osler's node and Janeway lesions, and vascular phenomena and rod spots all can be there.
Anything else? Anything is there in this patient with this type of lesions?
So this patient, she had rod spot and Janeway lesion and Osler's node.
All were there?
Yes, all were there.
Okay.
And further, patient can have blood positive which is not shown in major criteria. Some other blood culture positive other than the major criteria can also be a part of minor criteria.
Okay.
And
so basically, how do you treat a suspected? How you suspect infective endocarditis in an emergency room without echo, and how do you proceed with your treatment? See, these all things you are already getting a patient after diagnosis. When a patient come to emergency room, how will you suspect IE, and how will you start treatment?
So patient can come with history of fever.
So already somebody is having a lesion in the heart, infected like MR, AR, something like that. How do you suspect infective endocarditis? Pneumonia. We don't know, no? We don't know the patient. Patient is. We don't know the patient. We are first time seeing the patient.
So a patient with MR and all having a recent dental procedure or a history of any
just a fever.
So any fever of unknown origin in a patient who is having a cardiac murmur, we should suspect infective endocarditis. Suppose he has already undergone a procedure like dental procedure, catheterization, surgery, without antibiotic prophylaxis, we have to have double suspicion. Okay. So unknown fever, unknown etiology of fever is the first suspicion. Then how do you proceed? Next thing. So we are suspecting an infective endocarditis here. Okay. Then.
So, suspicion of infective endocarditis, we have to start with empirical antibiotics.
Okay, first investigation will be echo. Echo only, it can pick up some of the lesions. So, echo has to be done. If echo is not showing, you have to send for transesophageal echo. But that is not immediate. Okay, so you suspect infective endocarditis, you try to do echo. Then next is what?
So, other than echo, we can...
Next is what? Next, what is the important thing you do for this patient?
Culture.
Blood culture. So, 3 samples should be taken. How do you take blood culture?
So, for infective endocarditis, a patient should have 3 samples positive, 3 blood cultures of...
How do you take?
We have to take from 3 different venipuncture sites, which are...
you tell full.
Had to, initially, the patient should be wearing gloves and all, and...
So I understood. You are telling how to take a blood culture. That is every blood culture. It is same. Process is same. How do you take the sample?
The first sample taken, then within 1 hour, next sample will take. Then after 6 hours.
No, at least 1 hour gap has to be there. Why this gap? So different sites, different timing, at least 3 samples. Why all these things are important?
So to prove that the patient is having bloodstream infection.
So it's a continuous throwing of the bacteria from the heart. Just want to prove it that this is not a contamination. It's actually continuously patient is having hyperbacteremia. Okay. To know that, you are taking 3 samples from 3 different sites at 3 different timing. Okay. So that is very important. Okay. So 3 samples are taken, and next is what? So you have got a suspicion. You have done echo. You have taken blood samples. Then what to be done?
We have to start the patient on empirical antibiotics.
What is this empirical antibiotic?
Empirical antibiotic, we can start a patient on
What is this empirical antibiotic?
Suspecting the organism is
Organism.
an native or a prosthetic valve, depends on that. Suspect the organism. An native
Okay.
valve, we are suspecting more of a Staphylococcus aureus, Streptococcus viridans, and Enterococcus. Native valve, that is less than 12 months or more than 12 months. According to the organism varies. And targeting that organism, we will start the antibiotic.
Okay, so you are suspecting probable bacteria, which all bacteria can affect a transplanted valve or a infective valve, damaged
Native.
valve. But most of the time, your antibiotics will be, if you see the guideline, it will be almost same. Okay, only if transplant valve we are covering MRSA, that will be added. So, what is the first line treatment in empirical antibiotic? First line of treatment is what?
Penicillin.
You have to tell me. Penicillin.
84 international units.
One is penicillin. Second one is
Ceftriaxone.
So basically, we are covering both gram positive and gram negative. Penicillin, if you are starting, ceftriaxone has to be given. Like you are giving penicillin that covers gram positive, ceftriaxone will cover gram negative. Some doctors cover penicillin with gentamicin. Okay, same reason. Penicillin covers gram positive, gentamicin covers gram negative. Okay, if there is a transplanted valve or high risk valve, what else you add? Vancomycin. There we cover MRSA. So basically, it is only we know the spectrum of bacteria which is producing infective endocarditis, and we are covering it. Okay, even if you make a small mistake, nothing. There is no issue. You are basically covering 1 gram positive, 1 gram negative. That's all. Okay. So here most of the time, what we give is vancomycin with ceftriaxone. That will be the first line of choice in this type of patients. Okay. So here the patient is having MR. MR is due to the infective endocarditis, or it is having patient is having already this problem.
There was no previous history of any heart abnormalities or structural heart defect or congenital abnormalities.
Okay, so what do you think here? The MR is due to what?
The vegetation itself.
MR is due to vegetation. So MR as such cannot vegetation as such can damage the normal valve. It is very, very rare. So there might have a previous lesion in the valve. So what do you think? Is that a patient developing on a normal valve infective endocarditis or something else?
Mitral valve prolapse.
Mitral valve prolapse. So the commonest problem in this type of patient, what is the age of the patient?
23.
23. If there is no previous history of any heart disease, asymptomatic patient, then there is a chance of MR due to mitral valve prolapse. Okay. Can it be mitral stenosis and infective endocarditis?
Less likely.
There is a less likely chance for isolated MS with infective endocarditis. What are the lesions which are less prone for infective endocarditis?
Mitral stenosis, aortic stenosis.
Aortic stenosis, high probability. One more lesion you have to tell.
Tricuspid.
AST with AST and mitral stenosis has got a lesser chance for infective endocarditis. Whereas all lesions like MR, AR, AS, all these things are highly turbulent lesions. They all can have lesions wherever this jet is going and hitting. Okay, AS, there is a jet that hit on the aortic side. So infective endocarditis can occur there also. Okay, whereas ASD and mitral stenosis, lesions, that blood jet is not very powerful. So the injuries are very less. Okay, so it can be less. Okay, what else can produce mitral stenosis in the, infective endocarditis in this lady other than actual lesion like rheumatic heart disease? SLE is one important condition which can produce infective endocarditis in this type of patients. What is that called as? Okay, Liebman-Sachs syndrome. Any other condition other than that? Non-infective endocarditis is called as Mirandus endocarditis. Okay, so that is all seen in various conditions like SLE or cancer, malignancies, all these things. So we have to think that also. But here you have already got a blood culture report that is showing positive for gram-negative organism. So how do you treat this patient? You know that already it is Pseudomonas. How do you treat it?
So outside we didn't know that the patient had Pseudomonas, only know that
Gram
gram-negative
negative.
was.
Okay.
Here initially we did the blood culture, but initial blood culture was negative.
Okay. So why it is negative? Why? What do you think?
Outside treated.
So already partially treated infective endocarditis. So you have to believe that outside culture is actual culture report. After that, their patient has received antibiotic. Okay.
So further the patient was started on antibiotics. Here,
What antibiotic you give?
here initially we started with the same ceftriaxone and vancomycin, but
No, you know already that it's a Pseudomonas endocarditis. You cannot continue ceftriaxone.
we didn't know initially.
Okay.
Gram
You know
negative.
only gram negative. Okay.
So and later on we did continue with the further supportive care, and patient had left eye endophthalmitis also.
Okay.
So we did mitral valve repair.
What is that endophthalmitis due to? It is due to
Vasculitis.
Chorioretinitis.
In fact, that is due to the what is it called? Septic embolic.
embolic.
Okay. There is a problem in all these lesions, JNV lesion, all these areas. It is due to the septic embolism. Okay.
So we did the vegetectomy with the mitral valve repair. Commuteroplasty was done.
Okay.
And was showing a 2 into 3 centimeter large vegetation.
Okay.
And this vegetation was sent for culture, and the vegetation showed the culture showed Pseudomonas aeruginosa,
Okay.
which was only intermediate sensitive to polymyxin and cholesterol.
Okay. So what antibiotic you started
And the
after?
patient started on meropenem with the polymyxin.
Okay. So dual therapy is always important in Pseudomonas. Single therapy may not be working. Okay. What are the complications of infective endocarditis in emergency room? So now we have treated the patient at least 4 to 6 weeks. We have to continue the treatment. We have to do repeat echo. Vegetation should be completely removed from the valve. So that then secondary prophylaxis has to be given. Okay. What are the common complications of infective endocarditis in emergency room?
So patient can have cardiac complication, which include
Cardiac complication.
heart failure, and also ECG can have some heart block, and ACS can
ACS.
occur.
Okay.
CVA.
And then CVA can occur.
Okay.
And also patient can have septic emboli reaching to multiple sites, which can cause osteomyelitis. Then glomerulonephritis can occur.
Okay. Fingertips.
Finger osseous node Janeway lesions.
One of the most common problem is hemorrhages and distal gangrene can occur some patients if the septic emboli is huge. Here, since we are treating fast, patient is not developing all these things. If you don't treat, you can see after some days the fingers will be blue in color because of the obstruction of the perfusing arteries. Okay. Then
Patient mycotic aneurysm.
what is mycotic aneurysm?
Bacterial.
It's only a septic emboli, and there it produces an aneurysm and bleed. Mycotic aneurysm. Okay, it's not due to fungus. Okay, so septic emboli, and there it produces damage to the blood vessel and producing aneurysm there. Then, how do you follow up this patient?
Follow up, repeat echo has to be done, sir. And
Okay. This patient will have
antibiotic.
mitral regurgitation, heart failure will be there. How do you manage that? Young patient with heart failure, what are things you do?
Patient with you can start the patient on beta blockers.
Beta blockers. Ideal drug is beta blockers because it has to rate has to come down. That is the most important thing.
Then dapagliflozin.
Dapagliflozin, if diabetes is there, we can use. Otherwise, patient will go to hypoglycemia. That is a good drug in all these things, but since the patient is not diabetic, you may not use it. Beta blockers should be used. Then
valsartan, sacubitril.
Okay, that also instead of losartan or AC inhibitors, you are using valsartan sacubitril combination. Okay. Any contraindications are there for that group of medicine in this patient? Creatinine? If creatinine is normal, then you can use it.
This patient creatinine was normal, sir.
Normal. Okay. So anything else you want to tell about infective endocarditis?
The new one which guidelines was new one which came in was that new Duke's criteria which added the FTG PET to as a
PET
imaging
scan is
modality.
added to that because you will not miss any other infective focus. Okay. But it is all same. PET scan is available only in some hospitals. If hospital is having that facility, suppose you are not getting blood culture or anything, you can go for this. Otherwise, it is not going to add any benefit to the treating physician. Okay. Suppose you don't get a blood culture, then you can add that. Okay. How is the patient after
Patient
discharge?
is better right now, shifted from ICU to ward.
Okay. Valve? Only
Vegetectomy with mitral valve repair. Commissuroplasty was done.
Okay. Should we transplant the valve? What are the indications for valve transplantation mitral lesions? Indications for valve transplant.
Heart failure.
Acutely abscess and STEC valve we have to transplant. Otherwise,
Severe.
is MS is an indication or MR is an indication?
Severe.
Only MR is an indication. MS is not an indication for valve transplant. MS is an indication for valve transplant in which type of valve lesion? Medicine PG should know. If it's a calcified mitral valve, we cannot do this commissurectomy, all these things. Then you have to transplant. Otherwise, MR is a problem. MR, if the patient does not improve with your initial treatment, you have to transplant the valve. Okay. Here, did they advise anything like that or just discharge?
Right now,
it is not that. It is only the regurgitation is only due to the infective endocarditis, not because of the valve leak. It's only because of the endocarditis that ball is not allowing the valve to close. Okay. So anything like that other than infective endocarditis can affect the valve? Any tumors?
myxoma.
Atrial myxomas. What will be the clinical finding of atrial myxoma? It can mimic sometimes MR, infective endocarditis. What will be the clinical finding? What is the clinical finding of atrial myxoma? Syncope. Okay. They develop postural syncope. On some positions, it will come and block the valve. They develop postural syncope. So that is a very classical condition. They also can have fever, tachypnea, tachycardia, cardiac failure, everything. But they may not have fever like this. High degree fever may not be there. What is the typical fever of infective endocarditis? Typical type of fever.
Stepladder.
That differentiate between subacute endocarditis and acute endocarditis. It is like urinary tract infection, high degree fever, chills, rigors, toxicity. There are features of acute infective endocarditis. Whereas subacute will have very long duration, mild fever, mild type of symptoms. Okay, that's how clinically you differentiate. And blood culture is next thing. Anything else you want to add? Nothing. Okay, thank you.